2-minute version of the irony of my life. Born into chiropractic, there was no question about my love and infatuation for this profession. But inorganic chem, organic chem, biochem, every chem class was just nightmarish for me. I mean, the word just made me feel insecure. And I said, how am I going to learn this stuff? It's really just, my brain didn't take it in. And then I got to a class in chiropractic college, and it was lab diagnosis. And I didn't realize that all of that chemistry stuff that I resisted actually went in and found a place in my brain. And when I found lab diagnosis, everything woke up, and it was my epiphany moment. So I say, why am I teaching the subject that I hated the most? Well, because it became alive for me when I saw the insides of a human body. That's the best way I can describe it to you, but not the way we've all looked at it for our entire careers, which is X-ray, imaging, MRIs, CAT scans. Whatever you've done to take an X-ray and look at the inside of a body, I'm going to teach you what a biochemical X-ray is. That's what this instruction is for, how to look at a human being from another angle. You must have labs incorporated in your office. Most doctors are probably not doing labs. Most of you might not be or probably not dispensing supplements. You do not need to be a kinesiologist to do this. Everybody in New York State is licensed to write a script and send the patient to a lab. You don't have to worry about their insurance. Let the lab deal with it. You'll simply get the report emailed or hard copy mailed to you. I have my prescription pad here today to give you an example of what they look like. We have one during the presentation. And if any of you are sparked to get started with labs and you feel insecure and you don't know what you want to do, but you really want to do it, come to me and I will give you a script for yourself, personal profile to your health situations. You can run the lab. When we get the results back, we get on the phone or a Zoom and we'll discuss your personal labs and tell you what supplements and what direction to go with. I will tell you as far as supplements go, one of our biggest advocates, Dr. Dan Murphy in Northern California, does not do any kinesiology. He's an osseous adjuster, and he uses boatloads of NutriWest products. So I want to teach you how to apply nutrition to all of this. And of course, my company is NutriWest New York, so I know those products the best. I've been a customer using them personally and professionally since 1985. This is a company that was developed by a chiropractor, Dr. Paul White, for chiropractors. He worked very closely with my dad and Dr. George Goodhart in the engineering and formulating of the products when they started in the early 80s. So these are my roots. They go even deeper than that, but this isn't about that today. All doctors want to increase their income. Otherwise you wouldn't be normal. We love doing what we do, but we also have revenue and have to run a business. If you incorporate what I'm going to present to you into your practices, you will increase your income by approximately 30%, but it does go up to 40. So just think of what your annual is and just do the math real quick and decide if you'd like that extra money in 1 year. It simply happens because when you run labs, you're going to see what to bring down, all the highs. You're going to have to see what to bring up, all the deficiencies. Well, guess how you do that? You sell supplementation. Selling supplements is a wholesale retail part of the business. So you will increase your income on day one, on bottle one. You make money immediately. Fasting guidelines, real brief. That is good. Most doctors are billing. We have a cash-free practice. I'm cash-free. For sure not. We have a cash-only practice. We have over 3,000 applications with approximately a 2-month wait for an adjustment. So there will be no shortage if you take this dimension on in your office. So first screen, just introducing us. We are NutriWest New York. Forster Healthcare is my chiropractic end of things, and Forster Your Labs is the point phrase for where we're at here. Next slide is, and by the way, the color's all off on these, I apologize. Blood's usually red. It won't be today. Nutritional effects on blood chemistry. Good doctors know what to do. Great doctors know why. You must ask yourself the question why from the moment you leave your house. You have to walk out of your house as an 8-year-old curious kid, or you won't learn anything in life. But when you get to the clinic floor and you find something on a patient, don't treat it. Say, why is that spinal bone subluxated? Why is that elbow hurting? You don't just fix it. We're the doctors that talk about cause. The cause. And the philosophy of the cause keeps changing. Now we talk about the cause of subluxation. So there's my information, my partner, Dr. Horowitz. Amber is your go-to person. If you want anything done, you be nice to her. Order your products through her, anything, information, fact sheets on any of our products, seminars, just anything you'd like. Amber is the go-to person on that. Most of my territory is everywhere from the New York area, the 5 boroughs of Long Island, all the way up to Maine. We own 7 states. And most of our doctors receive their stuff in 24 hours, and you do not pay overnight shipping. It's just automatic because of the region. So you'll enjoy the service, and somebody is a person. You can email to you. There's so many ways to order. By the way, if somebody does not want to stock product in their office and go through the expense of that, you can order test kits for very little. And then when you find the products you want on your patient, they won't be leaving the office with them that day, but there's many ways to order them through us and through corporate, and you will still receive your benefit of the retail. You would get a check every month as if you were selling them in your office. Free of what Dr. Horowitz wanted me to bring out is most of you do insurance. We don't, but if you do insurance, your sales of supplements are cash, have nothing to do with billing. So it's immediate revenue flow. Blood, not red today. I would like to give you the insights, methodology, and tactics to what I do with these every day. Every day, meaning I get 500 to 800 of these a year. So every week there's 10 to 30 of them that hit my inbox. I have also organization methods for you. If you get busy with this, where do you keep the files? How do you make patient notes? How do you know who you're going to report to the next time you come in? Do you charge for the report? Do you call them or telehealth? Well, I can tell you all ways to organize that in your practice. So as we go through this, one of the greatest insights I will give you today is one of the most misunderstood things in lab diagnosis and managing a patient with a thyroid issue. I'm bringing it here today because it's a common problem, and I only have 2 hours with you. There's 8 and 12-hour presentations as well. We get a lot of time to go through this one. The next slide is a little more philosophical, and it's also where I get to put my patients on the spot. And when you put your patients on the spot, you make them feel uncomfortable for a moment, but then what they do is they become better patients. Because they know that next time I hit them up with the question, they're going to know the answer, because they don't want to be uncomfortable again. So that's a good thing. So if you don't measure it, you can't manage it. You have to do blood tests. You have to do labs. You have no idea what's going on otherwise. If you do kinesiology, one of our common tests is a bilateral tensor fasciolatum. That is an indicator, not pathognomonic, it's an indicator for possibly an iron deficiency anemia. It can mean other things, but it's very commonly associated to iron deficiency anemia. If I find that on a patient, are they mildly anemic, moderate, or severe? Now, I've had patients in my office that if I didn't run their labs, they would have passed away because their hemoglobin was 6.5 and 6.8, and normal is 11 to 13. If you hit 6, you pretty much stop breathing. So if you're not running labs, you could be doing a disservice by not referring a patient to an emergency room. The other thing I'll tell you briefly, and this is from Dr. Lundell from the symposium, that I wish more of New York State would show up. We do it in Arizona every winter, and it's a 3 or 4 day event that is just incredible. Top speakers from around the country. And Dr. Lundell, who works very closely with Dr. Murphy, who does professional testimony, said, if you don't do labs and you get in trouble legally, you're in trouble. If you do labs and get in trouble legally, you'll be okay. So another good way to practice anti-malpractice, do your labs. Objective, subjective, qualitative, quantitative. If you're not doing these 4, then you're not doctoring. This is simply called being thorough. Everybody wants their doctor to be thorough. I don't want my doctor to take a shortcut on me. So sit and get the objective on them. That's your physical exam. Tap their knees with the hammer. Get out your tools. We're doctors, let's doctor and not process and get to the next patient and look at the clock. Be all in. Subjective. That's only what they tell you. And the worst thing you could do as a healthcare professional is go by symptoms. Symptoms are probably the most misleading piece of information that come off the body. You have to be a good detective and you have to find out where it's coming from. When my lights weren't working on the 2nd floor of my home and the electrician was in the garage looking at the circuit breaker, my wife said, are you sure this guy knows what he's doing? Because the lights aren't working upstairs and he's busy in the garage. I said, I know he's finding the cause, honey. That's exactly what I do. We don't work on the symptom. It's not the fixture. Qualitative. Qualitative is muscle testing, skin temperature, all of the qualitative assessments you do in your office. Quantitative, labs. That's what we're doing here today. I find many doctors do their soaps pretty good. They go through the subjective, objective, they do an assessment, they do a plan. There's nothing quantitative there. Nothing bothers me more than the psychiatric profession who's giving psychotropic drugs and doing 0 quantitative analysis. It's all subjective. How do you feel? Oh, let's bring you up a little. Let's bring you down a little. You must do quantitative analysis. Don't take supplements until you remove the blindfold. So people go, well, you know, everybody needs vitamin D. Let me get some more sunshine. Well, that's a big misnomer because sunshine is D2. It's cholecalciferol. That's vitamin D. Cholecalciferol, like cholesterol, is a fat. It's a hormone. Vitamin D is not even a vitamin. And does everybody need it? Yes. And how much do you need? What's your dosage? Are you absorbing the type you're taking? How do you know when to alter the dosage? Blood test. So take off the blindfold, know what your mineral levels are at, know what your cholesterol levels are at, know what your sugar is, check your uric acid, check some inflammatory markers. I do an entire seminar just on inflammatory markers. We could do about 7 of those. What's your vitamin D level? That is the question that I ask every one of my patients when they come through the door, or if I'm walking from the garage to the office and I see them in the street, which is quite common. I'm pretty popular in my neighborhood. And, hi, Dr. Forster. I go, hi, how are you? Good morning. What's your vitamin D level? And they go, last October, 59, October 23. I go, good. You're still in the club. If you cannot answer that question, you better be able to answer it soon. Go back and look. Inspiration with information, which is what I hope you get here. I hope people walk out of here and feel inspired to start looking at blood tests on yourself, on your family, on your friends, on your patients. Anyone you care about and love, you should be looking at a blood test. How often? Most people, if it's fine, once a year. If there's an issue or I have to follow something up, then we do it sooner. How much sooner? Well, it depends what's going on. I mean, if I've had cases come in with hepatitis, and they're going to be checked in a couple of days. I've had other issues where I check them in a week. But typically, if I want to check something midstream, somebody comes in with a horrendously low vitamin D level, a 17. By the way, optimal range is 60 to 70. Anything above 40, you're going to be okay. Anything below 40, you're not going to be okay. The major effect of vitamin D is on the immune system. It also takes place in every other cell cycle in your body, including Krebs. So your energy is going to crash if you don't take D. Remember, it's a hormone, not a vitamin. So it's going to drive neurotransmitters also. The ones you're familiar with, like dopamine and serotonin, and GABA, and norepinephrine, and epinephrine, and a whole bunch of others that you haven't investigated. And when you do labs, we do some of these cascades as well. We do neurotransmitter testing through urine, and we do saliva hormone testing, which is much more accurate than blood hormone testing. So when it comes to hormones, I shift over to saliva. Whole nother course. Okay. Educate and navigate. Basically, you know, if you don't, then you are putting on a blindfold and getting on the LIE. Dangerous. Reference ranges. You know, these are very misunderstood because the reference ranges that you're given on the blood tests are ones that are based on, think about it, the reference ranges are based on a national average. People, where do we live? We live in dopamine nation. We live in a cigarette smoking, McDonald's eating, overweight society. And so the reference ranges that they give you are absurd for our patients because we're not in the business of putting out fires. We're in the business of health and longevity. I drill every patient on what their plans are for their 100th birthday. What are you going to do? I know what I'm going to do. I've had a lot of thoughts about it. I mean, first of all, it's going to be the funniest day of my life. I'm just going to laugh on that day. I don't think I'll be able to stop. I'm going to buy myself a birthday card and say, happy birthday to me. It's just going to be a funny day. I'm 100. So there's average ranges, and patients are not coming into your office for average health care, I hope. They want optimal health care and optimal ranges. That is usually the middle of the middle without getting crazy. For example, if it's a 0 to 20, we go 8 to 12. A 10 is perfect, but there has to be some shades of gray because we're human. Nobody is flatline, we're homeostasis. We float around the middle. That's the healthiest human. So some optimal ranges are anything over a certain number. So we're not looking for the middle of the middle. And some of them, the lower the better. And I can teach you all the optimal ranges, of course, if you come to other of my seminars where we embellish on all this stuff and it's not a 2-hour cookie. And also if you want to call me, I'm available. Here's a good one. Why is this good? Because we live in New York. Are any of your patients like stressed? You know, I mean, you know, we live in a stressed environment, in a stressed state. The HPA axis, or hypothalamus pituitary adrenal axis, is the vasovagal syncope, or FFF, known as the fight, flight, and freeze mechanism, which is a coping mechanism for your nervous system. Will you faint? Will you be able to deal with the stress? What's going to happen with if your nervous system shuts down and you faint, that actually saved you. That's why we have this vagal nerve response. And if any of you attended Dr. Silverman's seminar, he spoke a lot about the vagus nerve. Man is on the money. Listen to him. Anyway, when you have HPA axis cascades going on, these are called catecholamine cascades. Briefly, they start with an amino acid called phenylalanine, quickly goes to tyrosine. Tyrosine is the precursor for dopamine. Dopamine goes norepinephrine, which is why people feel better after a chiropractic adjustment, because you've activated the norepinephrine, which then converts to epinephrine, which is adrenaline. And that's why they named it EpiPen after epinephrine. So people who are not cascading through those hormones I just mentioned properly are going to end up anxious, nervous, and feeling acute stress. Acute stress is bad. Chronic stress is bad. But there are good stresses in this world that actually strengthen your adrenal glands and your nervous system. So not all stress is bad, but when you're going through catecholamine cascades and your adrenals keep getting hit, then it's going to be bad, because then it's a chronic daily stress, even a low level. When we run blood tests on these people, that I know they're in the HPA axis mode because they're coming into my office in a spin, we check ACTH, adrenocorticotropic hormone, so that we can find out more about the adrenal pituitary connection. We check DHEA, that's dihydroepiandrosterone, not androsterone, androsterone. Why? Because it drives androgens. What are the androgens? Those are the estrogen and testosterone molecules, not the progesterone. Cortisol, do an AM and a PM check. We do 4, but if you want to do basic blood stuff, do an AM and a PM cortisol, because cortisol is your barometer of how your patient is experiencing stress. Remember, it's never stress itself. Some people, you tell them what they can't do and that motivates them. Other people, you tell them what they can't do and they believe you. So not everybody reacts the same to stress. So when some people wake up stressed because they know they have to battle another day in the jungle. Other people come home and they're stressed from a whole day in the office or whatever. So it depends who you are, and then you'll know when to control cortisol levels on your patients. I have some patients that wake up and their cortisol through the roof, and they go to sleep with their cortisol through the roof. And the last few to cover, and we're right there, was insulin, which is the hormone that comes from the islets of Langerhans, tail end of the pancreas, to break down disaccharides like sucrose. That's table sugar. That will break it down into a glucose and a fructose molecule. Fruit sugar is purely fructose. It's a monosaccharide. That is trouble because fructose requires cortisol to be metabolized. When you metabolize a monosaccharide through cortisol, you're going to get fat deposits. And where are they common? Visceral, and very common to the liver. It's called fatty liver, or steatorrhea, or steatorosis. And now that people are understanding those terms, and the doctors need to sound smarter than they really are sometimes, it's now called parenchymal liver disease, just in case you get that back on your sonograms. That's the same as fatty liver, and those are people eating fruit and demanding so much cortisol of their body to manage it. And then there's also fat deposits that can go to the brain and cause dementia, the most common one from fruit being Alzheimer's. And then we have prolactin. So this is a hormone that's secreted by the anterior pituitary gland, very commonly looked at in breastfeeding. If a woman has any discharge and she's not breastfeeding, this is the critical one to run, and because it will pretty much rule out a pituitary tumor that is causing an elevated prolactin level. TSH has an asterisk next to it. Everything I do is intentional. The reason why it's there is because it's called thyroid stimulating hormone, and it's not a thyroid hormone. So I want to clear that up right here, right now, because endocrinologists who do this for a living only are getting this wrong. So please understand this. TSH, thyroid stimulating hormone, is a pituitary hormone. It's not a thyroid hormone. If I were to rename it for the nomenclature, it would have a lowercase p and then uppercase TSH, much like we do for messenger RNA or mitochondrial RNA versus nuclear RNA. We put little n's and we put little m's next to those RNAs to differentiate where it is in the cell. Well, we should be doing the same thing here because everybody's getting it wrong because it was named thyroid stimulating hormone. So it must be a thyroid hormone that stimulates it. Well, it doesn't. It's not what it does. What TSH does is it comes from the pituitary gland, the anterior pituitary, and it comes to the thyroid on a negative feedback system, which is most of the body. There's a couple mechanisms that are positive feedback, but everything else in the body is call and response on negative feedback systems, much like fueling your car. When it gets to the top, the thing will click off for you. That's negative feedback. When there's enough TSH dumped into the thyroid, tells the pituitary shut it off. Okay, great. Now what happens from there? That TSH, after it hits the thyroid, stimulates the thyroid to do what thyroids do, which is produce thyroid hormones. There's only two to really learn, T4 and T3. What's the difference in the two? How many iodine molecules are attached? So think of it like a car with 4 seats. You have 4 receptor sites, 4 available seats on a thyroid molecule. If you attach 3 iodine molecules to it, you've got an available seat, right? T3, that's called active. What's active? Actively looking for another iodine passenger to fill the 4th seat. Those usually don't live very long, 1 to 3 days. They grab an iodine and instantly become a T4. That's why it's called 4. It's now got 4 iodines attached to it. And now it's a complete molecule. When molecules are complete, they get very complacent, and that's called inactive, because it's not actively looking for anything. T4s hang around for a long time, usually 5, 6, 7 days. And then they release one of their passengers. Now they become a T3 and they're actively looking for an iodine again. And in a few slides, I'm going to explain the importance of iodine that goes way beyond thyroid. And the last one, T4, it would be, you'd run this to manage an HPA axis patient. And in your slides, in your notes, you'll see that all these different corticosteroids and androgens, catecholamines, peptides, all come from your adrenal glands. So adrenal glands are like really important, and they're not spoken about enough, and it's a real New York thing to speak about. Also, if you think about the word, does anybody know what renal means? Yes, kidney. What does ad mean? Above. So the adrenal is the thing that sits on top of the kidneys, like a little hat. Where's the cause? We're chiropractors, so we're always busy with the cause. Well, the first thing makes me laugh, fatigue, because I think that every one of us experience this every day in the office. Somebody or several people are going to come in and they're going to say that word. Hi, how are you feeling this stuff? I'm fatigued, I'm tired. Well, yeah, and then they think it's normal because they got a bunch of kids and they're working jobs and this and that. Yeah, no, it's not normal to feel fatigued. You can do 3 and 4 jobs and get a good night's sleep and keep going. I'm living proof. So where's the cause if it's fatigue? What about weight gain? Loss or gain of weight that's unexplainable. And we're going to go over a slide of a patient of mine, a young lady who came in, and she gained 50 pounds unexplainably. She didn't change anything in her life. And every week she got on the scale and it was another 5 pounds, another 5 pounds, another 5 pounds. She came in freaking out, what's going on in my body? A slow or increased heart rate can be a clear indicator of an HPA axis issue. A brief note on that clinically, if you have a patient with a slow heart rate and you're doing lab tests and one of our routines is to run magnesium, please make this note. If you write magnesium on your slip, you will get back magnesium serum, which is useless. I don't know why it's in the software anymore. Why is it useless? Because if you run 1,000 of them, you're going to get 1,000 norms. And there's no way that 1,000 people that all have a magnesium test are all perfectly normal. So the serum test is something we negate. What you will order is magnesium, and then in capital letters put RBC, red blood cell. Then you will get the actual magnesium reading of the patient systemically. Optimally, you want that to be at about, well, let's say over 5.5. 5.5 or greater on magnesium RBC reading. Very important. My reason for bringing this up is magnesium is one of the most critical minerals that all my patients, my family, all of us are taking and monitoring through the blood. If you're lower than 5 or 5.5, you're getting on our complete MG, which by the way is the only magnesium product that I know of made in this country, maybe in the world, that has magnesium malate, citrate, and glycinate in it, the important one being malate, because that's the one that will cross the blood-brain barrier. Why is that important? Because we all need neuroplasticity. All of our brains have to keep regenerating. So you don't want to lose cognitive skills and short-term memory and all the things that your brain is doing for you when you're young. If you take the complete MG, 3 to 4 of them a day on average for an adult, you will maintain a lot of your mental health. The other thing that's in this product that is mind-blowing, because the engineering in it, is they put coconut fiber in it. And the coconut fiber is a fat-soluble fiber that actually helps the malate cross the capillaries of the blood-brain barrier. It's just a set of capillaries around the hypothalamus. That's what the blood-brain barrier is. It decides if things are going to stay in the body or go to the brain. That's why psychotropic drugs can affect your brain, because they engineer them to cross the blood-brain barrier. Anxiety, irritability, nervousness, trouble sleeping, muscle weakness and tremors. Lots of people have that. I mean, muscle weakness? We're chiropractors. We see a lot of that. Irregular and absent menstrual cycles. I don't know how many think to check out the pituitary, the HPA axis, if there's an irregular menstrual cycle. And vision problems and eye irritations, usually not thought of with this. I think that's it on this slide. Let me tell you, where is the cause? Where is the cause? Is it in the hypothalamus? Is it in the pituitary? Is it in the thyroid? Is it in the adrenals? I found it odd when I learned the HPA axis that they left the T out. What's going on with that? It's hypothalamus, pituitary, adrenal. I mean, the thyroid's a player. And so now we're going to see why. Because where's the cause? Could be in the thyroid. Could be. But what if it's not? What if it's in the pituitary? How would you know? Do you have to refer them out to an endocrinologist? No. You can run a very simple thyroid test. And by the way, when I say simple, it's only 6 tests you write on the page, and you've got everything that you're going to know about the thyroid and differential diagnosis to say, what should I be treating or should I be referring? Here it is, people. This is one of my gems, because you can be the world-class champion in your neighborhood. I think it's important to work on your personal mastery, to increase your professional capabilities. If you learn this, you will know more than everyone in the neighborhood on this. You get the reputation of, oh, I know this guy, he does all about thyroid. You gotta go see him, he's the guy who can peg it for you. He's got natural things to fix it too. No drugs, no surgery. I know a lot of people that went to him that said, do I only treat thyroids? No. It's funny how you treat a patient for a particular condition and that's who they refer, because they think that's what you can fix well. So thyroid people send in thyroid people. Migraine people send in migraine people. I don't know why it goes like that. You got 5 examples here. After I teach you this, you will know how to differentially diagnose between a primary thyroid and a primary pituitary problem with your eyes closed in the middle of the night. It's so easy. I don't know why more people aren't doing it. The 5 examples are a functional hyperthyroid, or the autoimmune version of that, which we call Graves. A functional hypothyroid, which is the more common situation, I'll explain why, or the autoimmune version of that, called Hashimoto. Or the differential diagnosis part of it, which will tell you that it's pituitary, eureka. Then you can treat them. You don't have to treat the thyroid. You're going to treat the cause of the thyroid. It's a primary pituitary. And the thyroid's going to be all messed up looking, and they're going to be put on Synthroid usually. And by the way, I don't understand that one because it really should be Armour, which is T3, T4. It's the medicine that has both thyroid hormones. But the Synthroid, which is the commonly one given out, is only T4, which makes no sense because if I was giving it, I'd only give T3 to make the iodine available. The whole thing makes no sense to medicate for this stuff, but that's all they've got. So you can be the primary doctor for thyroid problems. We've got a bunch of products to move all of these values and get thyroids perfectly balanced out. I've done it thousands of times. I can walk you through it. So is it a thyroid gland primary or a pituitary gland primary? First, I want to tell you, I put thyroiditis next to hypothyroid because there is not one hypothyroid condition that exists on the planet that did not go into thyroiditis before it went to hypothyroid. Doesn't exist. So if a patient comes in with hypothyroid, you kind of know where you are in the time chain. That's a more advanced situation if they're already hypo. If they come in with thyroiditis, I cut them at the beginning of the story, because that's how they're all going to go first. And you kind of know where you are, meaning you might want to take a prognosis. The faster they come into us, usually the faster they get better. If people wait to see if stuff goes away, or they're trying a whole bunch of medicine that is probably masking the situation, so the problem is getting worse while they think it's getting better, because what do pharmaceuticals do? They override the God-given physiology. Well, that's a good thing. That's what they were designed for, and that could save lives. But when you use them for functional approaches like this, you're actually burying something under a mask while the fire is really coming up. And then when you take that mask off, you can have a much bigger deal to work with. So I know patients that refer to me, they tell anyone, they go, if you're going to go to my chiropractor, don't wait. Otherwise you're gonna add on a whole bunch of visits. The faster you go to him, the faster you get out. It's just how it goes, it's normal. So the hyperthyroids are all thyroiditis, and this is all how a thyroid story would begin. You will see blood tests on my first example with a low TSH and an elevated T4. The second lab I'm going to bring up is going to be the autoimmune version of that. So you're going to see a suppressed TSH and an elevated T4, but you're going to see that I ran markers. Remember I said there were 6 tests? So they're TSH, T4, T3. You're familiar with those 3 now. Then we have the autoimmune markers. Those are TPO, that stands for thyroid peroxidase, and TGA small b, thyroid globulin antibody. Those 2 are going to tell you if it goes into Graves' or Hashimoto's. If it's not, if they're negative, if they're normal on your autoimmune markers, then it is purely functional thyroid. You'll find a lot of them when you start running these blood tests. You know, the more you know, the more you look. The more I learn, the more tests I order. Because like, how could I leave that out now? At the end, all Q&A thing. The third example will be the functional hypothyroid. The fourth example will be, you'll see, the TPO and the thyroid globulin antibody will clearly depict that it's not functional, it's Hashimoto. The fifth example will be the pituitary, where the TSH is either normal or low. I'm going to work the pointer on this. Whatever. Let me show you. If the pituitary has a normal TSH or a low, and the T4 is also low, go back to the negative feedback I taught you. As the pituitary is dumping into the thyroid, when the thyroid has enough, it's going to say, I give, I'm good, I'm full tank. Well, what if it's low TSH and there's low T4? What does that mean? It means that you know you have no gas in your tank, and you pulled up to the pump, and you put the pump in, everything's connected, and then you never pulled it up. You never put gas in. Well, if that's happening, then your pituitary is not responding. Because that thyroid is calling for TSH and it's not getting it. The car's calling for gas and it's not getting it. So now you know you got a pituitary problem. Why is this important to differentially diagnose this way? Because it's really hard to find labs that beeline you to pituitary. So what we have to do is we have to kind of find it in from the side door and from the back door, and by checking the thyroid and backing it up to the ACTH and the DHEA, and then all those hormones up. Because what test would you do to check out a hypothalamus? What would you do? A CAT scan, maybe? What's that going to do for you quantitatively? I mean, if you took a CAT scan on everybody's hypothalamus here, they'd all be normal. So what am I going to do with that clinically? So we have to find out about this from other ways. So that's why the differential diagnosis is so critical, especially in a endocrine axis. Anything to do with the pituitary, thyroid, adrenals, ovaries, testes. Here you go, folks. These are real people. This was my patient, 26-year-old female, and she came in with eczema and unexplained 50 pounds. So, she didn't come in telling me any of the stuff on the list. Remember fatigue, rapid heartbeat, slow heart. Oh, why did I bring that up? Very important, I'm backing up for a moment. Complete MG, I got off on a tangent because that product excites me so much. Be very cautious of magnesium levels. You gotta do blood tests. Cautious of magnesium levels on patients that have slow heartbeats. Make sense? Magnesium is gonna slow down the heartbeat. It's gonna go too slow. So there's a profile for you. Everybody else can use magnesium. It's the same thing on people with blood thinners. Be careful with blood thinners. Like omega-3 is a blood thinner. Quercetin is a blood thinner. Most people don't take enough of this stuff anyway to thin their blood. So it's not like if you take a teaspoon, you're gonna be in trouble and get a bleed. TSH here. By the way, I'd like to discuss the optimal levels first. You see the reference ranges? What's the reference range on TSH? 0.4 to 4.5. What would optimal be? The way I do this is the middle of the middle. So we take the low number and we take the high number. We add them together, divide by 2. Now you got the mean. Without getting crazy, little shades of gray, remember. So 2.7 would be great. I have so much experience with stuff. I like the patients that actually run a little lower than the perfect mean. 2.4 is like, when I get into 2.47, I'm tickled. And they start off like this, 0.01. That means there's none. There's 1/100th of a nonogram of a unit systemically. Where do we take blood from? It's called a venipuncture. What does vena mean? Vein. This is not arterial blood. Venous blood is empty, it's void, it's on its way back. It already dropped off all its passengers. All the goodies are in the arterial blood. So realize this is all tagging of proteins. All the technology behind this is finding out kind of what was there. You interject?
Yeah, I just want to jump in for a second about the normal range on the TSH. How we can find sometimes when it's missed. That's a really wide normal range. You're talking about the optimal ranges, which is correct, but there'll be a lot of times that it's happened a few times I've noticed. Somebody comes in like 1.1, 1.0, and then go back and look at the last test, 6 months before, they were at 1.7. All right, go back to the last test before that. A year ago they were at 3.0, now they're at 1.0. That will not flag on the test as an out-of-range test, but there is clearly something wrong with that person. There's a problem there, and there's a clear pattern, but it's still in the normal range. Many doctors will miss that. So go back and look at the context. Do they have previous blood tests even before this one, and look at that pattern.
So it brings me to the best point of the whole seminar. If you leave with nothing else, please leave with this today. My surrogate grandfather, Dr. Napolitano, my father was very closely with Dr. Goodhart. These guys all taught me one lesson as I moved into doctor world. They said, Jamie, correlate. It's all I heard from these guys. So no human being should be defined by a test. I don't go on this and run with it. This has to be profiled. You have to do other tests. If you muscle test, you're muscle testing. If not, you're checking vitamins. If not, you're asking them more about their history. Checking skin temperatures, looking at a lot of different things about their body. You have to take an x-ray. At the end of this, I'm gonna give you the craziest story that happened on Wednesday. I didn't get a chance to drop it in for you guys, but you're gonna get it here today because it happened 48 hours before I left for this. I was like, perfect timing. That will blow your mind at the end. The last 2 minutes, I'll do that. T4. The free T4 is a 2.0. We can see that's slightly above the range of 0.8 to 1.8. And so this is a functional deal going on. The thyroid globulin antibodies and the peroxidase, here's your autoimmune markers. Thyroid peroxidase, thyroid globulin antibody are both well in the range, less than 1 is normal. So that's not autoimmune, but it's totally a thyroid problem. Is it pituitary? No, because the TSH is in the basement. It's 0. I mean, there's none there. But it's not Graves' disease. This can be fixed easily. And by the way, autoimmune disorders are becoming more and more popular due to the chemical food industry. And as a result, you go and see more of it in practice. They can be reversed. We're seeing autoimmune response every day in our office. When you turn immune systems back on, then that's what happens. Next slide is the example of the hypothyroid that has gone further into an autoimmune situation. So take a look here. I know it's a little skewed, but you also have your notes. The TPO, the thyroid peroxidase, is abnormal. I'm sorry, which one is this? I'm having trouble seeing it. The thyroid stimulating hormones is 16. Don't pay attention to the A1C on top, which 4.8 is perfect. But thyroid stimulating hormone 16. So that is what? A hyper or a hypo situation. Anybody? Hypo. That's why TSH ran up. The T4 is running low over here. 0.8. The TPO, I ran. And where is the antibody? That should be there, and I do not see it. My apologies. But the TPO is there, and it's less than 15. Normal from this lab is less than 34. So this is clearly the opposite. This is a hypothyroid, and it's functional. Does everybody get that? Are you with me? No. Okay, back up. TSH, low. T4, high. Lock that in. TSH low, T4 high. TSH high, T4 low. That's it. It's just the opposite situation on the next patient. What did this person have? 32-year-old male, anxious with excessive sweating. That's what he wrote on the form. And this is what I found on him. So we got to work. Now I know why he's feeling that way. At least one of the main reasons.
I'll just jump in for a second just to clarify in case anyone doesn't get it, is that those first two cases are sort of clear hypothyroid and hyperthyroid, but it's not autoimmune.
Correct, they're both functional.
Autoimmune markers are normal.
Correct.
In this case, it's a thyroid peroxidase and the thyroid antibodies are normal.
You're all with
that hypothyroid and hyperthyroid, so it's not an autoimmune condition.
Everybody's with us? Yes? Okay, good. So here now we're going to go into a little different situation. Take a look at the TSH on top. 0.005. That's 1/5000th of a unit floating around their body. They have no TSH, 0.00. What's the T4? T4 is 14.1, elevated. Let's go to the autoimmunes. TPO, thyroid peroxidase, 717. Below 35 is normal. That's a scary number, right? Well, wait till you see other ones I've seen in the thousands, then 700s don't scare you. And the antibody, there, up there, thyroglobulin antibody, right under prolactin. So this one I did the full profile that I covered with you on the other slide. You've got TSH, T4, T3, prolactin. I did the ACTH, I did the cortisol on the bottom. So we're seeing all the stuff that I went over before. A lot of times I get the blood tests from a previous doctor. So they never run it the way I run it. This is more of the way I do them. And I usually have to send them back to the lab and just fill in the blanks. So you'll see that the thyroglobulin antibody, anti-thyroglobulin is 99, less than 40 would be normal. So because clearly both of these autoimmune markers are very elevated, and you can see the pattern in the TSH and T4 with the no TSH and the high T4, and that is clearly autoimmune. Okay?
What do you do with that?
We're going to get there in just a moment. Here you got TSH, 32.97, obviously very elevated. You've got a T4 that's low, right? And then you got your thyroglobulin antibody. There it is, over 1,000. Less than 1 is normal. They stopped counting. They just said over 1,000. And then the thyroperoxidase, didn't come out on the slide. Let me tell you what that is. Nope, didn't come out. It's elevated, take my word for it. So this is clearly the autoimmune situation of Hashimoto's. That's what that looks like when you get these tests back. Here, folks, is the pituitary primary. This is what they'll look like. So you've got the TSH, that's a 0.9, and the range here, this is a different lab. This is a little something to be aware of. Don't get into a pattern where you do everything from a couple of labs and you get familiar with their reference ranges and you start not looking. This is a patient that brought her stuff into me from a different doctor, Dr. Shahuki, and so it was going to be a different reference range than I'm used to. So I saw that it's 0.9 and it's 0.8 to 1.4. So that's really, does that a norm? Because it's just squeaking in by a tenth? No, that's significant in a healthcare practice, maybe not in crisis care, but we're not crisis care physicians. We're primary healthcare providers. So that becomes significant in low and high normal. And the TSH, 0.73. Remember I said 2.5, 2.7 is kind of what we target? So this is obviously a low TSH with a low T4. I will not be treating her thyroid. No supplementation goes to the thyroid. She's getting manganese, which isn't in the slides today. But if you want to write down, if you get a pituitary major, you're going to order manganese-GC from Amber. And you give them 1 a day, and then you rerun the blood test in 4 months. Why 4 months? Because, rewind the tape back to school, red blood cells live for 120 days. That's why. So why check something that's not critical prior to the next generation of blood cells being generated? Let a whole, you put the vitamin in, you let that blood circulate through, and 4 months later, when you check their levels, you're gonna have a nice clear reading on where those vitamins are clocking in. And it's very exciting for the patient too to see these numbers coming up. It's real report card stuff, and they stay very involved in their treatment, and basically they become prophets and disciples, and they run out into the streets and they blot your name all over the place, and then...
Does that mean third generation?
What's that?
On the blood test, TSH third generation?
TSH is third gen. Yes. I'm not sure what you're asking.
Did the other one say third generation?
Yes, some of them just don't mark, they're all third gen. I don't know why they put that. I thought you were asking me about my son. Here we go. How do I fix it? How do I fix it? Now that I found it, what do? Call Dr. Forster and feel helpless? No. You start ordering these products and profiling them. I do it with muscle tests. You can do it with just book knowledge. If you would like, Amber will get you the catalogs and all the paperwork on this stuff. Our core level thyroid is just that. Core level is NutriWest's way of saying the major. Like the major subluxation or the major cause or the place where we're going to focus our adjustments on our patient, they call core level. Core level is a way of saying, instead of taking 5 different supplements for your thyroid, let's make a multi-approach to a spot on the body. So we make them for every organ and gland of the body. So this is the core level thyroid one. It's got vitamins in it, minerals, herbs, amino acids. So you get all in one. You give that to the patient at 1 in the morning and 1 in the evening with food. It has to assimilate with food. And 4 months later, we run the 6 thyroid tests, which are TSH, T4, T3, TPO, thyroglobulin antibody, and iodine. Total thyroid number 2 is just a little offshoot of the core thyroid. It's almost the same, it's a cousin. The difference is this kelp. Kelp is loaded with iodine. So that makes that a different and complete thyroid product, slightly different from the other. And that's another thing about this company is if we call in, if Dr. Murphy calls in and we have an idea or we're having a problem because a product isn't working because it's missing a certain CoQ10 component or something, they do the engineering and development and they get that stuff into the product for us. They work with us on that. Thyroid Plus, real handy stuff because it's a tincture. People who can't swallow pills and children. Or the people who, in my practice, muscle test well on the drops, not the pills. They're going to get the drops. Those are dispensed at 10 drops twice a day. That does not require food because it's herbal. It's the equivalent of a cup of herb tea, except they're herbs targeted to support thyroid. By the way, thyroid problems target to C7, T1 subluxations. So if you have cervico, thoraco, transition area patients who are always like kind of saying, like that might be a thyroid problem because it goes right to C7. That's what innervates the thyroid. And the last one is iodine rescue. I want to stay on this one for a moment because it's misunderstood. This product is 22,500 micrograms, not milligrams. I had an endocrinologist call me, freaking out. What are you giving your patient? They're going to end up in the hospital with iodine toxicity. I said, why is that? They go, there's 22,500 milligrams in here. You take one of these and you're in trouble. I said, read the label, doc. It's micrograms, it's a dot. The amazing thing about that dot is how effective it is. I give this stuff to patients and their iodine levels come up quick. So watch it. Do the blood test quick. Don't wait a year on this. Do it in 3 or 4 months and see if they're good. Most people, including in this room, are iodine deficient. The range goes from 40 to 90. Most of you are in your 40s. So you're the bottom of the normal range. That's not good for health. You want to get it up to about 70, 75. This stuff will do it fast. Is iodine for the thyroid? Yes, because that's where it's converted, conjugated, pushed out to the body. But what is actually iodine for? If we study just the iodine molecule, the purpose of iodine is it's an anti-inflammatory. Iodine is an anti-inflammatory for every single cell of your body. We have 300 trillion of them, except red blood cells. Why is that? Because red blood cells don't have a nucleus. Iodine can only affect a cell with a nucleus. It needs DNA to work. Proteins. That's what your chromosomes are. The strands of proteins. We're going to go into the next section of this presentation this morning. That's going to be it on thyroid, pituitary, differential diagnosis of these glandular things. All Q&A at the end, please. At the end. Please write down your questions. I'm happy to answer them at the end. I don't want to keep stopping in the middle of the seminar to do it. Homocysteine is an inflammatory marker. Chiropractors, please start running these on your patients. This will get your patient healthier living longer, and it will keep you out of legal trouble. Why? Homocysteine is the tag to determine if you are going to treat that person with a cervical osseous adjustment or not. And we all know the reputation and the hoopla and the talk about all that stuff that's not true. And we know it's not true. But here's the deal. If your homocysteine levels are elevated, and I would consider that to be anything over a 10, but this is one of those ones where the lower, the better. It can't be too low. This is going to be a determinant of if there is possibly some plaque buildup in the carotid arteries and the vertebral arteries that could be let loose into a sequestra and create a TIA, a stroke, or a clot if it's on your call and that patient's on your table when it happens. You better learn homocysteine. Just for the chiropractic end of things for cervical adjustments only. But there's so much more I'm going to teach you now about this because it's really a liver functioning thing and it moves around some of the most important B vitamins in the world. And B vitamins are all cobalamines. B vitamins are also coenzymes. B vitamins are catalysts. B vitamins move our cell cycles around. The Krebs cycle clicks through all of its turns clockwise because of B vitamins. So otherwise you wouldn't have ATP. No energy. You know, our Krebs cycle is the determinant of the difference between life and death. That cell cycle is spinning right now in all of us. That's why we're here. When you're younger, it spins faster. And as you get older, it spins slower unless you do things like we all do. What are the things? Well, the three-legged stool analysis is what we give our patients. It's simple. One leg of the stool is going to be your diet and your lifestyle. The other leg of the stool is your treatments with me. And the third leg of the stool is your supplement program. If you leave any of them out, it will not be stable. They always ask, you know, can I work this? Can I not keep the diet, take the vitamins, come for the adjustments, and still respond? It's not going to be great. So as an inflammatory marker, we use it. We also use it as a chiropractic profile. Should I be doing traction and stair step, or can I get in there and get a cavitation? B6, B9, B12. B6 is also known as pyridoxal 5-phosphate. That is how we sell it. We call it P5P for short, because nobody wants to keep saying that. B9 is folate. The inactive form of folate is called folic acid. The active form is called folate, and B12 is called, usually, methylcobalamin, usually. But we're going to get into that in a moment. I'm going to show you how the cycle runs and how you can benefit your patients in more ways than one by just learning this little piece. But at this moment, I do want to take out like 3 minutes for all of you to turn around and just hear what Dr. Horowitz has to say about how the liver can methylate these B vitamins and make sure that you are methylating. And if you don't know what that means, we're going to cover it. Dr. Horowitz.
Just want to get a feel of this. Everybody sort of know the term methylation. You've heard it before. You know a little bit about what it is, what it means.
No.
Methylation, in short, is that the turning B9 and B12 into the active forms inside the body. It's chemical reactions that have to occur inside the body, and it's an enzyme. It's a gene. So the gene is typically referred to as MTHFR. Anybody ever heard of that? Seen MTHFR before? And it's actually something that can be run on a blood test as well. So, but what it does is the MTHFR stands for methyl tetrahydrofolate reductase. It's the gene or the enzyme. I use those terms synonymously. But it's the gene that codes for the enzyme that is the catalyst for this reaction. It makes this reaction occur. And in the case of B9, you're talking about folic acid being turned into folate inside the cells of the body. In the case of B12, you're talking about cobalamin. In most cases, it's cyanocobalamin getting turned into methylcobalamin. The methylated forms are the active forms. Our bodies, our cells, cannot do anything at all with folic acid. But with folate, it can. And not only that, but just like Dr. Forster said with iodine before, folate and methyl B12 are things that are needed in every single cell of the body except for red blood cells because there's no nucleus there. So it's literally DNA repair inside the mitochondria of the cells, every single cell. So that reaction and that conversion is very important. And it happens to be that MTHFR is one of the most common genes to have what we call a SNP or a variant. It used to be just called genetic mutation. Genetic variant, or a SNP, they're all really meaning the same thing. It just means that that process is not happening properly in your body. Two ways that can happen. Number one is genetics. You got a faulty copy of the gene from one of your parents or both. If you have that, if it's one parent only, it's called heterozygous. Anyone ever heard that term before? Exactly, right? If it's both parents, it's called homozygous. And again, on the blood test for MTHFR, they can measure that. So there is some value in saying not only do you have it, and you can confirm it on the patient, but you can actually also see if they're homozygous. Well, they got a really big issue here. You know, we have to get on top of this and get this working properly. It's the stats are somewhere. It's a too wide of a range. But they say generally 30 to 70% of the population have some sort of an issue with the MTHFR gene. So cut it down the middle. Say it's about 50%. You can also genetically be fine. And what's the other way that you can get MTHFR? Well, that's just being unhealthy. Lifestyle, diet, exercise, lack of sleep. Diet is a very big one. It's a big way to get, it's the most common way probably to get a whole lot of inflammation into the body, so much so that the gene that was working properly before is now not. So you can create that after the fact with your diet and lifestyle. Another very big way is the sickness and illness. Any kind of illness, but like it's very common in viruses. We saw it in COVID and flu all the time. So it's another way that you can get the MTHFR to not be functioning after the fact.
Thank you. Okay, so back to the slide for a minute just to finish up here. Homocysteine converts in the liver to either methionine or cysteine. If it goes down this road with B6, that's the P5P, then you're going to get what's called a little bit of sulfur toxicity in the liver. Those are the patients that show up with achy joints. They're not arthritic. They just say like, I don't know, like, it's just like achy all over. This is clearly what's happening. The product we use for that is called L-cysteine. It is a sulfonator. It removes the sulfur from the blood and the joints feel better. It is the precursor to something you are familiar with. Glucosamine sulfate, chondroitin, GCMSM. You've heard these terms? People go for that for their arthritic swollen joint. Well, L-cysteine is the precursor to all that. We don't work with the end products much in the office. The whole practice is very much based on substrates and precursors. It doesn't mean we don't give glutathione, which is the strongest antioxidant in the world to reverse cell aging, but we give a lot of NAC, N-acetylcysteine, because that is the precursor to glutathione and will cross the blood-brain barrier and help with neuroplasticity. So these are some of the variations of all these B vitamins of how we're working them in the practice and how we're trying to spread the word for other practitioners to do the same. You can see that the B6 is involved mostly here, and that the B9 and the B12, folate is B9, and B12 are busy going over to the methionine. If your homocysteine methionine cycles don't take place back and forth consistently, then you're going to get like pretty fast liver toxicity. Those are the patients that come in nauseous all the time too. if you hear that. They just say, I'm almost like nauseous, like I feel seasick. It's probably this problem. This is a cool thing to notice. Betaine, as in hydrochloride from choline. This mechanism right here is based on B6 coming off the homocysteine. That's why they have it in the diagram here. B6 is a precursor to hydrochloric acid. So the next patient that comes in with the I'm taking Tums moment, or Nexium, or Prilosec, or Acifex, what we call the purple pills, they're probably B6 deficient and not producing enough betaine hydrochloride. Understand that most people that have burning and reflux and GERD and esophagitis and all this stuff, they are hypochlorhydric. And the symptom is that they have too much acid. Remember at the beginning I said, do not go by symptoms. Chiropractors that go by symptoms are definitely going to go down the wrong road, and your diagnosis is going to dictate your treatment. So if you get the diagnosis wrong, nothing's going to go right. So that's a lot on this one slide. This is a bragging moment for me. I love NutriWest, obviously, and NutriWest is the only company that has gone to this extent to break down B vitamins. Why is this so important? Because when you understand blood tests and how to work Krebs cycle and all the other cell cycles, you want to find supplements to interject in the various clickings of the cycle. Because as you know, and you had to memorize this at some point, what turns into what turns into what turns into what along the Krebs cycle before we actually enter into an electron transport where we can drop off and gain some NAD molecules and get ATP, fuel, right? Adenosine triphosphate, energy. That's what we all want. So adenosyl B12, classic for methylmalonic acid, MMA, an inflammatory marker involved in electron transport. Let me embellish on that. MMA is something I order regularly on a blood test. When the person comes in and they say that word to me, Doc, I know everyone's tired, I'm working like everybody, but my fatigue is something like abnormal. I feel drugged with fatigue, not just tired. I immediately run an MMA on them, methylmalonic acid, because if they are elevated in this acid, it means they are adenosyl B12 deficient, specifically adenosyl B12. If you give another form, they probably will not respond with this particular acid. And they will not be continuing their flow into electron transport, and they'll continue to be fatigued, and no one will find it out because they didn't run a simple blood test called methylmalonic acid. And the answer was right there. Hydroxyl B12. This one's interesting. It'll absorb slowly, and it will convert to the other two types. So this is really helpful with a patient, that sensitive type, where they go, every time you give me something or do something, like I immediately respond. Like other people have to take 2 bottles worth, and like they feel it on the 5th pill. These people go slow with, they have to absorb hydroxyl B12 slowly, and in the body it will convert to the necessary molecule that the body calls for. Adenosyl B12 to enter into electron transport and maintain a methylmalonic acid, that's a normal range, or it converts into a methyl B12, which is more of the homocysteine cycle that you just saw, and that's going to affect your cardiac and liver analytes. Analytes is just the word for the names of the tests. They're analytes and values. Glucose, 80, analyte values. When you hear the word analyte, that's all it means. And some of the tests will come back with that word on it. Don't get thrown. So methyl B12 for your homocysteine and for your elevated CRP, C-reactive protein. We run these every single day. I run so many blood tests that when I have some free time, I sit down and write up 10 scripts for the day with nobody's name on them. Because I know the beginning of what I'm going to write, then I leave the end off because I don't know if I'm going to run thyroid on them, if I'm going to be looking for this. So I just leave a space to write all the specialty tests. But everybody gets a certain foundation from me. There's no patient that doesn't have the vitamin D, vitamin A, and vitamin K check, and magnesium, because otherwise you're going to have BMD problems, bone mineral density problems. These are all your osteopenia, osteoporosis patients. All of this is so manageable and so easy. And the liver are all the transaminases. That's your ALT, AST, GGT. We learned them as SGOT, SGPT, and GGTP. They changed names. Here you go. Literature from PubMed.com, also your NIH.gov website. It is your most valuable research tool, not Dr. Google. This is where you're going to get the facts. Homocysteine is a thiol group. It's an amino acid. It's a protein. It's a piece of a protein, like most things in the body, which naturally occur in all humans. Homocysteine is degraded in the body, broken down, through two metabolic pathways. While a minor part is excreted through the kidneys, the chemical reactions that are necessary for degradation of homocysteine require the presence of, here you are, folic acid, which we say folate, because you're going to give your patients the active form. Because if you give them folic acid, they're going to get gunked up. They're going to come in and they go, Doc, I'm taking your folic acid, I feel worse. You got to get them on the folate, the B6 and the B12. Consequently, the level of total homocysteine in the serum is influenced by the presence or absence of the B vitamins. An elevated level of homocysteine, hyperhomocysteinemia, and homocystinuria, when homocysteine starts spilling into your kidneys and goes through the urine, then you got a really advanced situation. It's connected with occlusive artery disease, especially in the brain, the heart, the kidney, and in addition to venous thrombosis, chronic renal failure, megaloblastic anemia, and others, osteoporosis, depression. I mean, it goes on and on. Alzheimer's, I mentioned, pregnancy problems and others. We have a family practice, and with that, 50% of the practice is in diapers. We have so much pediatric stuff going on in our practice. I'm not running homocysteine levels on my 3-month-olds, but I do run them from about 9 years old and up, and we have a lot of family members in that age group. Elevated homocysteine levels, we're over here. Elevated homocysteine levels are connected with various pathologies both in adult and children population. Causes of homocysteine include genetic mutations, Dr. Horowitz mentioned, enzyme deficiencies in the methyl tetrahydrofolate reductase, that's the MTHFR gene, this variant that you can measure on blood, but you don't need to. We got our workarounds for that. The synthase form of the molecule, the cystathione form. Hyperhomocysteine can be caused by deficiencies in folate, B12, and to a lesser extent B6. There's your 3 B vitamins again. It just keeps coming up. What influences methionine metabolism? Additionally, homocysteine can be caused by a rich diet and renal impairment. This review presents literature found in the etiology of blood levels disorders. That's what we're studying, blood, so that's perfect. Yeah, I can't say enough about this one. Again, use it as a chiropractic profile to stay safe. Use it as an inflammatory marker, along with your C-reactive protein, along with your A1C, along with uric acid, which is now an inflammatory marker. It used to just be something to profile for kidney stones or gout. We now know that elevated uric acid levels and optimal ranges is anything over 5 is elevated. Don't go by these lab ranges, which I think go up to 7.5, and then you've actually got gout. So anything over 5 on your uric acid levels, start to address it. It can also elevate blood pressure, hypertension, can elevate sugar levels, hyperglycemia or pre-diabetic. It can also elevate cholesterol levels, hypercholesterolemia, all from uric acid. I recommend you read a book called Dropping Acid. Cute title if you were born in the 70s by David Perlmutter. Chapter 2 and 4. Nails this. He also covers all of why not to eat fruit and goes extensively into the fructose molecule and how it can affect your cortisol and stress levels and screw up your liver and brain. So find out about these things and read these guys' books. There's some great literature out there. I'm the student. I don't come up with this stuff. Dr. Horowitz.
You had wanted to talk about B12 and the ICD. Want me to cover that or want to?
No, that's you. That's your cover. Just give Dr. Horowitz your attention for a few minutes.
Just an A.
And then we'll move to the supplements.
Anatomy and physiology for a second here. It's B12 first into the stomach in order for it to get absorbed properly in the body. This is not even talking about the genetic possible issues of being able to convert it properly. This is just how it actually gets absorbed into the blood. First stop is in the stomach. The stomach makes something called intrinsic factor. And intrinsic factor binds to the vitamin B12. So it has to happen there and only there. And then it flows and swims down through the entire stomach and about 20 to 28 feet of small intestines till it gets to a spot at the very end of the small intestines. There's a valve there called the ileocecal valve. Now, in our practice, that valve is extremely clinically important. It correlates to all sorts of signs, symptoms, including back pain, SI stuff, headaches, congestion, obviously gas, constipation, bloating, those kinds of things. Anyway, is there ever a day that goes by in your office that you don't treat at least one?
Never.
And it's more like if you treat 15 people in a day, you probably see like 10. You're working on 10 ICUs.
Absolutely.
It's just that common.
But understand the important correlation he's making, that it's not just an intestinal thing, that the ileum is where the B12, the intrinsic factor releases
Well, that's
it.
what I was getting to
Yeah.
next, is that the intrinsic factor binds the B12, swims through the entire small intestines, and at the very end of the small intestines, at the site of the ileocecal valve, that's where it finally gets absorbed into the bloodstream. So, even without genetic factors with B12, you can have, if you have a chronically inflamed stomach, reflux, ulcers, that kind of thing, you're going to have a problem with B12, and it has to be addressed. If you have an IBS or Crohn's or something chronic, like a leaky gut, a chronic problem with the ileocecal valve, you will also have B12 issues and deficiencies because you cannot absorb it into the bloodstream.
Yeah, celiac, like all. It's all going to be B12 deficient patients. Okay, and here's another one for you. If a patient comes in and you think they might be B12 deficient and you haven't run a blood test yet, a quick thing you could do is a physical exam. 2 physical findings for you. I don't go by symptoms. I do go by signs. Signs are objective. They're things that I'm finding, and when I leave the room and I send my son or Dr. Horowitz in the room, they're going to find the same thing. That's an objective sign. Symptoms is what the patient's feeling. That's going to put me on the wrong path. What are 2 classic signs of B12 deficiency? Real easy to grasp. Stick your tongue out. If it's red and it looks like a kid that just finished a cherry lollipop, they're definitely B12 deficient. The redder, the more deficient. The other thing is, you can ask them, do you ever get like tingling in your extremities? Like you're just driving along or you're walking and all of a sudden like you feel like a fizz go through your hands or your feet or your arms. That's B12 deficiency. That's the criticalness of, in our practice, we teach women who are in childbearing years that you must work with us for 4 months before you conceive, because conception is the most critical part of pregnancy. Not the first trimester to prevent miscarriage. That's important too. But the blueprint is cast on conception. Yes, in the 3rd trimester, we don't want preemies. But conception is the key blueprint moment. If you don't get that right and get these women healthy and all these vitamins balanced out before they conceive, the kids get born with problems. Classically, B12 goes to peripheral problems. I have a friend who has a child with 9 toes. She conceived B12 deficient. He's got 5 on one foot and 4 on the other. Midline problems, usually benign. Folate problems, cleft palate, tongue tie, spina bifida, anything down the midline is your folate problems. Anything on the extremities, usually the B12s. If you have women getting pregnant in your practice, you have to start running these B vitamins on blood tests before they conceive. I mean, it's a way to save the next generation. Please save questions for the end.
My wife had anencephalous fetus who was found to be deficient.
Living proof, right here, doctor in the front row. Tell, they couldn't hear you.
My wife had an anencephalous fetus and she had had 4 other miscarriages, but she was found to be B12 deficient when they did testing after that.
Okay, I kid you not. I have friends and family who have been given birth to children with these problems. This is all avoidable stuff. You gotta run labs. I think that was it on this. So here's what we do to fix people. This is the only company, I'm very proud of it. Adenosine, methyl, and hydroxyl B12. Which one do they need? Well, if you ran the methylmalonic acid and it's elevated, buy some adenosine B12. It's one a day. By the way, they're lozenges. It doesn't mean you have to let them melt. Lozenges gives you 3 modes to get it in. You can suck on it like a candy, you can chew it and swallow it, or you can swallow it like you do any vitamin with water. But it's the option of it. And if you're going basic, B12, not sure what to do, let me stay with something safe, go with methyl B12. Problem with the label on this one is it also has folate in it, which is what makes it great. It's a complete product of methyl B12. It's methyl B12 with folate. It's the active form in there. It doesn't say it on there, but when you read the back of the label, you'll see it. So when in doubt, and you just want to go down the middle and not get too fancy, you go with this one. And you can also work with that one with homocysteine levels elevated and C-reactive proteins, and then the hydroxyl B12. And that would be targeted to homocysteine and C-reactive protein issues. I think that covers it. Here's your P5P. This is the active B6. This is 5-MTH folate. You can purchase them separately. In other words, if you run a blood test, B12, folate, and the B12 comes up perfect, and you just want to boost that folate, you can do that. If you want to boost both, you'd go with the methyl B12, which has the folate built in. And I also love that this company separates everything. It really bothers me when people take supplements that have D and K in them. First of all, the K in the wrong forms usually, and it doesn't give me a chance to doctor them, because what if their D is low, which it probably will be, and their K is fine, because they eat a lot of broccoli, which is loaded with K. Now, if I'm giving them D with K, I'm driving their K too high while I'm trying to get the D up, and that can lead to clotting problems. K is important for clotting, the opposite of blood thinning. So these are very targeted. I'm going to talk about P5P for another moment, because one of our accounts orders only P5P. We have 350 to 400 products. Everything from basic vitamin A and B complex and C and zinc to functional medicines, herbs, homeopathics, amino acids, you name it. I mean, this company makes like so much stuff. And this one doctor calls regularly and says, send me another 4 cases of the P5P. And they go quick, like a month later, he's calling again, another 4 cases of P5P. So Amber flags me, and she goes, you should call this guy. Because he's loving NutriWest, but I think he thinks we only carry one thing. So I call him up, I go, Doc, what's all the hype about P5P? Well, we have so many products. He goes, I just want to tell you, I have a lot of patients with allergies. Seems to be what I attract. Everyone comes in with these histamine responses. Your B6 has eliminated every patient's allergy in my entire practice. No one's allowed to leave the building without a bottle of this stuff. So that's why he just runs through it like water. Why? Because P5P is a catalyst between histidine and histamine. So it regulates your histamine responses. He taught me that. I was using this for all the other things that I just taught you. The same as people don't realize it's a precursor to hydrochloric acid. So these vitamins are not just the classic book applications. You can learn more, you can do more. But the only way to know is by looking. The only way to do that is a blood test. And when you know more, you look more, and when you can do more, you can do better for your patients. Methyl Renew is, I can't say enough about this product. I mean, when in doubt, go Methyl Renew. You say, I haven't taken any courses in how to methylate. I don't know that work yet. And by the way, I suggest you look up Jared Almon. He works with NutriWest, and he teaches the course on methylation all over the country. And then you can learn how to methylate patients. Methylation, point phrase, repairs DNA. So if you want to repair your DNA and get your bad switches turned off and your good switches turned on, you'll learn about methylation. This is the phenotype or the expression of your genes, which is constantly changing. We can't change your genotype, but all of our products will change the phenotype, the expression of your gene. And therefore you'll get health and longevity. That's the message. Methyl Renew has all of the methylating products built into it, the methylating B vitamins, the cofactors, everything you need to methylate a preparation. If you use this, use it with some caution, meaning 5 days to 2 weeks in, give them a call. How are you feeling? I feel amazing, what's in this stuff? Or I felt amazing for 5 days, and the last 3 days I like crashed. You're over-methylated. But you call me, and you say, this is what the patient said. What does that mean? What do I do? And I walk you through it. That's the Methyl Renew. Really quick, really effective stuff. I don't know that I get through a whole bottle with a patient. It's that good. It doesn't mean I don't go back to it. And by the way, all of our tablets and pills have a 5-year shelf life. All of our drops have a 3-year shelf life. And everything is stamped with manufacture date, not expiration date, to keep accuracy on that. So we know the exact date it left the plant, which is in Douglas, Wyoming. B complex. This is a complete B complex, all the B vitamins and all of the methylated forms. No folic acid in here, it's folate. Okay? No, the B12 is going to be methylcobalamin. Like everything is the active form of the B vitamin. I don't know too many people who don't need B vitamins because stress, pollution, things you can't control deplete B vitamins. So, just check your B vitamins. I break them down on the blood tests. I look at all the B vitamins.
I just want to jump in for a second. Exactly. The 5 products that specifically work on MTHFR for methylation. Start with I like to go from the strongest to the weakest, or slowest acting. The Methyl Renew is the strongest methylator that we have. It has all of the vitamins and it has a bunch of other things that help absorb and have it work in the body better. That's the strongest one. Second strongest one is that B complex right there. Like you said, just a straight B vitamin, and it has everything already in the methylated form. If you can you go backwards one slide? The P5P is actually not really a methylator in terms of dealing with MTHFR. So I'm leaving that out of this particular conversation. But 5-MTH folate is just a folate. It's not all the B vitamins. It's just the folate in the active, already methylated form. So that's one. You can go back one more. Then the next two. Methyl B12 lozenges. You mentioned that it's actually both methyl B12 and folate. And then the one right next to it to the right is the hydroxyl B12. That's the slowest acting and weakest form of the 5 methylators that we have. It's a slow acting B12 and it's only a B12. There's no folate in that one. So those are the 5 methylated products that we have.
In that order?
Thank you. What's good about this company and the way we like to practice, both of us, is that we individualize it to the patient. So some people might need that Methyl Renew. It might be a severe problem, and it's been going on for a long time. We really need to push it. And some people or kids, it's based on size, might just need the lozenges here, the methyl B12 lozenges with the B12 and the folate, or the hydroxyl B12 lozenges, which is just the B12. So we can mix and match in terms of the strengths based on what's going on with the patient.
Okay, some more B vitamins and ways to control homocysteine levels. NutriWest has also taken the liberty of giving you, like the fast lane, easy street. If you do not want to learn about every B vitamin, and I can't imagine why you wouldn't, they're very interesting. B vitamins are basically food for nerves. So if you want to keep your nervous system healthy, go check your B vitamins. They made homocysteine redux. So you can just run homocysteine levels on your patients and not even know what you're doing. And if it comes up elevated, just give them a bottle of homocysteine. It's 1 a day with a meal. And 3, 4, 6 months later, check their homocysteine level again. Again, 10.0, 10.5 is the cutoff. The lower, the better. I will just put one note in there. It's becoming a popular product because of the athletes. That always seems to make things go viral. They're using nitric oxide for quick recovery of lactic acid. Well, nitric oxide is great stuff and it dilates blood vessels, which means it lowers blood pressure. It enhances circulation. It's great for a whole bunch of conditions. But if you're taking nitric oxide for good health reasons, and you run a homocysteine level because you came out of this course and now you go into your office tomorrow morning and you're doing more, better, smarter work, and it's elevated, it doesn't mean they're necessarily elevated, because nitric oxide will elevate homocysteine levels. So know when you're getting a false positive. Core Level Health Reserve is our multivitamin. I'm proud of this one for a couple of reasons as well. Every one of the B vitamins in it, and it is a real B-based multi. Every one of the B vitamins is in the methylated form, and if you do your homework, start to look at multivitamins from around the world. Most of them have some copper in them. Copper is bad for a vitamin, very bad. These people used to have it, they took it out. Again, what I love about this company, they're not stuck, they'll move, they're not antiquated. They're actually always ahead of the curve and doing things before anyone else. We have a longevity vitamin with ergothioneine in it, which is the extract of the mushroom, before anybody else was talking about mushrooms and longevity and enhanced immune function. We also have an amazing immune product called Glycan Renew, which is the complete mushroom formula. So anyone, we use these things also not as a primary. There are patients that come to us, I have to be the secondary. Maybe they're in the middle of a chemo treatment. So their primary is their internist and their oncologist. And the patient says, well, while I'm going through all that, can you support my immune system naturally so that I can respond to my medical treatment more efficiently? Yes, this is how we do it with all these immune enhancers. So the Core Health Reserve, no copper, methylated B vitamins, it's just amazing stuff. One a day, it's like jet fuel. And this was a bloody good time. Each of these bullets I take very seriously. I really hope that you received great value from this presentation. I'm not being wordy. I really tried to deliver value to you. I want to thank you and Niska very much for having me. I appreciate this opportunity to teach you. I love doing it. I love chiropractic. And the team at NutriWest New York is here for questions, case management, and supplement distribution. There's our website. And thank you very, very much. Safe trip home.